Welcome. My name is Chris Schaffner, founder and creator of Your Community Health Plan. So, how did we come up with Your Community Health Plan? Well, it all started in 2008 to 2010 when I was the industry representative on the Blue Ribbon Task Force for our own state employees health plan that services 700,000 plus state employees, has a budget in excess of $3 billion. And they were looking at ways of controlling costs and improving the health of the state employees that they cover. In 2010, I then presented a solution for the state health plan. That solution was also concurrently being used in the city of Asheville. It's called the Asheville Project. And there are several key components that any employer, regardless of size, should use when they're looking at building a health plan. That is fundamentally better access to primary care and better access to pharmaceuticals. If you compare that basic premise with where we are today in insurance options, there's a stark contrast. Most plans that you are currently participating with today or currently being sold in the marketplace are known as consumer-driven health plans or high-deductible health plans. And those plans force an employee to pay premiums out of pocket on a monthly basis. And then when they go and seek care, they then have to pay more money out of their pockets. There have been numerous studies that have shown that those two things have detrimental financial impact on both the employee and the plan itself. Employees avoid care. They don't take their drugs like they're supposed to, which means their health conditions become worse. And when they do finally go and seek care from a provider, in most cases, it's because something else has happened, meaning their health condition has gotten worse and the expense to the plan and themselves has gotten greater. So what is it and why do we call Your Community Health Plan something based upon intelligent plan design? Well, it's quite simple. When John Mile, the risk manager and HR professional in the city of Asheville, was looking at controlling his costs and improving the health of the employees that worked for the city, not knowing any better, he went down to UNC Chapel Hill and said, well, gosh, primary care doctors and pharmacists, what should I do to help these people? They said two things. Number one, everyone needs to have a primary care doctor that they consider their own so that they can call them and consult with them without worry of plan cost. That means removing copays, removing coinsurances. Well, as you can tell, that's in direct contrast with where the entire industry has gone with high deductible health plans. The second piece of that is you need to be able to take the medications to manage common chronic conditions, again, without any cost share. And most of those medications are not really expensive. Again, a stark contrast to the health plan of today that charges the participant 100% of an inflated cost for those same drugs. Now, what we have done is in working with both local state providers, which we have networks of independent primary care as well as independent community pharmacists across our state. We also collaborated with the likes of the National Alliance of Healthcare Purchasing Coalitions. That is a national organization that represents the Walmarts, the IBMs, the Bank Americas of the world, the Fortune 100, the biggest of the big, that are having plans that sponsor multiple hundreds of thousands of people every year. And they say the same thing. We need advanced primary care to do their job. And if they do, what does that mean for the plan? Well, according to the National Alliance, it means 27 to 30% less downstream spend in claims outside of primary care. That's a big number. We also know that if we work with local, independent, and community pharmacies, that most of the medications that we need our people to take and that they need access to count just pennies. So we have avoided any cost share with both primary care and those basic generic meds. For any specialty claims or facility claims, we're handling those with a direct contract. But more importantly, with all of the data that's available to us today, it's possible for us to know which providers offer the highest quality outcome at the lowest possible price. Now, that doesn't mean that they're just in network, because someone being in network just means that they've agreed to the terms of the contract, regardless of quality, regardless of outcomes. So you may go to a provider that is in network under a traditional carrier plan, and that provider may be the highest cost and the lowest quality. As many studies have proven, there is no correlation between cost and quality in procedural-driven healthcare, which is kind of amazing. This is all why transparency matters. Another key pillar in what we have done at your community health plan is focus on transparency. You wouldn't spend $20,000 out of your household budget on anything without reading multiple reviews by industry experts, multiple anecdotal stories from friends that might have purchased the same product or service. You do your research. But in many cases in healthcare, that's impossible for the average person to do because there is no transparency. What does this mean to you and your employees and all of our money? If you look at the first dollar bill where you've got two sides, administrative cost and claims, that kind of represents a fully insured plan that you might buy from any national carrier across any state in the United States. You have no insight into the actual risk that your company and your employees represent. You have no way of knowing what or where those dollars are actually spent. You're at the mercy of that carrier, their network, their RX plan, and your money. How do you know how much you're spending, and do you have any control over changing behaviors that might allow you to save more money? Well, that's exactly what your community health plan has done. We are the fiduciary to the plan that has the expertise to break down all the costs separately. When we look at the administrative cost, the stop loss insurance cost, which is there for the real reason we have insurance. Things that are beyond our control, that if they happen, they are financially devastating. This could be a car accident, a dread illness that you have been identified as having, or some other very random event that would cause an extreme financial impact to your or the plan's budget. Then we look at actual claims cost. And if we look at claims cost, we start with primary care and community pharmacy as the baseline, knowing that that doesn't cost a lot of money, in order to keep you away from venues of care that may not offer real value to you as the plan participant or you as the plan sponsor. And in doing so, we are going to show you exactly where the money is going. And if and when there is money left over at the end of the plan year, 75% of that money goes back to the plan itself, which the employer can then use to offset future costs associated with the plan, or they may choose to give it back to the employees in the form of compensation. Because at the end of the day, every dollar that is running through your health plan is either yours as an employee, or it's the employer spending your money that you forgave in wage in order to get this benefit on your behalf. The other 25% of that money goes to those primary care providers and community pharmacies that are helping you experience higher levels of service and better levels of care. So, what does that look like in terms of pharmacy? If you look at this slide, NADAC, N-A-D-A-C, that stands for the National Average Drug Acquisition Cost. That is a state-based and federal government-based model of real price of what a drug costs. So when we were developing your community health plan in association with the North Carolina Association of Pharmacists, our MACO RX partners, and our clinical pharmacy partners, we said, let's be very clear as to what the drug costs and what we as a plan and as a participant are asking you, the community pharmacist, to do. So we said, okay, what does it look like today? So if you were in a traditional fully insured plan today, your generic drugs in this example would have cost your plan about $103,000. And that's ingredient cost, the cost of the drug, plus a dispensing fee. And in this case, that dispensing fee was around 89 cents to $1 per prescription. Under the NADAC model, if we were to reprice the exact same prescriptions, that the ingredient costs are only $46,700. As you can tell, a significant lower number than in the fully insured or traditional pharmacy benefit manager world. So then we said, okay, community pharmacy, if we are removing your incentive for profit away from the cost of the drug, we need you to be engaged more advanced on the clinical side and to provide a higher level of service to our patients who are coming into your doors so that you can help give them more advice and be readily available for giving them assistance in medical decision making. We use an $8 dispensing fee because that is the number that makes it profitable for the community pharmacy. Well, it turns out that if we as a plan are covering, in this case, 100% of that $8 dispensing fee, we are still saving 17.5%, almost $20,000 over the traditional PBM that operates in almost every health plan today. So we're saving 20% just on the drug piece, which typically represents between 25 and 30% of your total spend, a big number. Now let's look at why we do an unbundled approach versus using one provider solution to cover everything. Our unbundled approach looks like this. You have Benefit Plan Administrators Incorporated. They are the third-party administrator. They are the person that basically holds the checking account and pays a claim as it comes in for your employees. We have Cielo Star, which is our online enrollment capability, as well as the provider of our reinsurance for the plan. CPESN, they're our clinical pharmacy network, which monitors and evaluates the delivering of this higher quality, more clinically engaged pharmacy service. We have Community Care, independent physician network, as the base of your access to primary care. Custom Benefit Solutions, Christy, the broker, that is the liaison between you, your employees, and everything else that happens through the plan. The North Carolina Association of Pharmacists, they're a third-party sponsor that says this is a better way and we want to be involved in it. And that is partnership with MACO RX, who is also a North Carolina company and involved in the NADAC Plus model development. Now, all of these companies represented on this slide have very specific jobs to do to make the plan work. If you were in a fully insured environment, you would have one logo on this screen, and it would be one of probably 4 national carriers that control every aspect that I just outlined to you. And you would have absolutely no transparency into the outcome. And what does that mean? In financial terms, dollars and cents, if your premium is $100 a month and you invest $1,200 a year in premium cost, you've done your job, you exercise, you eat right, you go to the primary care doctor, you take all your meds like you're supposed to, and you only incur $300 in claims. Where does that $900 go? That $900 goes right to the carrier's pocket. You are inflating their profit margin by taking care of yourself, which to me doesn't seem to be right, which is why in our model, that's where your savings comes from back to the plan. Now I'll turn it over to Vinay and let Vinay explain a little bit more in detail about our pharmacy benefit.